speaker will be Professor Hugh Tae-won from South Korea. Professor will talk about the efficacy of the minimal invasive reduction with a circuit cable in spiral and oblique subtrochanteric femoral fracture. Professor, please.
Thank you for introduction, Chairperson. Good morning, everyone. I'm Hugh Tae-won from Korea. I think this meeting is the meaningful first step for Asian orthopedic trauma. It's a great honor to be here today. The topic for today is the efficacy of minimally invasive reduction with circular cable in subtrochanteric fracture. As you know, if the subtrochanteric fracture occurs, the proximal fragment shows varus, flexion, and external rotation deformity. If reduction failed, it will cause malalignment and long entry point. A surgeon should be faced complications such as non-union or mechanical failure. So, during the treatment in subtrochanteric fracture, correction of deformity and achievement of proper alignment are very important. Most surgeons usually use the fracture table of the treatment of subtrochanteric fracture to restore length and axis. For restoration of rotation, we can check the retrotrochanter shape, cortical step sign, and diameter difference sign. And then, if needed, we can use the hematostatic forceps to reduce the proximal fragment residual deformity. We can usually get a good result through the, as mentioned, technique like this. This is the initial X-ray of the 55-year-old male patient with subtrochanteric fracture. Common plan will be using a fracture table and minimally invasive reduction and final fixation with IM nail. I performed the operation through the plan. First step is traction to restore length and axis. And the second step, rotational deformity was corrected using Kelly clamp. But finally, slight degree of varus alignment remained. This is a post-operative X-ray. Although IM nailing is the standard treatment for subtrochanteric fracture, but high-quality reduction with IM nail alone is very challenging. So we can use the temporal reduction with wiring through a circular wire passer, and this technique can improve the quality of the reduction in subtrochanteric fracture, like this. In a long-term follow-up study of subtrochanteric fracture, varus reduction and non-union were reported to be high. This demonstrated that maintaining good reduction in these fractures is very challenging. For spiral or oblique subtrochanteric fracture, minimally invasive reduction with circular passer and wiring have been employed, achieved better results than IM nail fixation alone. This is the subtrochanteric fracture. Two wiring was performed to reduce the fracture alignment like this. And then finally, good alignment was obtained. Another case, 75-year-old female patient with a similar fracture pattern. First traction and put the circular wire passer and gradual tightening resulting in good alignment. This is the final radiographs. But previous two cases had relatively lower deformity cost in proximal fragment because they were old age and having a low muscular volume. This case is with the relatively higher deformity force and comminuted fracture in subtrochanteric area, 64-year-old male patient. This is post-operative radiograph. You can see the residual gap and poor reduction status. Fortunately, bony union was achieved, but he suffered from delayed union. Another relatively higher deformity force case in proximal fragment. This image from C-arm. It seems like to achieve good alignment after wiring, but during the last tightening, the wire was broken. At the time, it took a lot of power to reduce the fracture size. So I changed the reduction technique by clamp-on-shafted reduction, and I did the fixation and wiring again. This is a post-op radiograph, but through this case, I think 1.5 millimeter stainless steel wire is not strong enough to maintain reduction of the fracture size in some cases. Another higher deforming force case, 63 male patient with a similar fracture pattern. During the operation, first one wiring was performed in the proximal portion, and I did the second wiring, one more wiring in distal portion, but during the final tightening, second wire was broken. So I did a retry, but I could not reduce completely. This is post-op radiograph. It seems fracture appeared to have been well reduced, but in other direction X-ray, and the fracture gap is remained. So stainless wire is not enough to close the gap sufficiently. Although wiring is good tool for reduction in subtrochanteric fracture, but there are some disadvantages of wire, such as wire breakage or insufficient strength in case with higher deforming force or as displacement. If you're using a cable as an alternative to wire, a cable has multi-filament structure, better tension control, and prevention of kinking and breakage. In a biomedical study, have reported that cable has higher strength. At the time, diamond cable could be a good alternative to wire. And then I checked the possibility that cable can, through the circulage wire passer, is possible. So next case, cable reduction through circulage wire passer was planned. First step traction and check reduction. You can see the large gap in the lateral view. So circulage wire passer was placed around the fracture site and the cable was inserted and tightened it. After reduction with the cable, IMNER is very easy technique. This is a post-operative radiograph, shows good alignment. We did perform the comparison study between wire and cable group in subtrochanteric fracture. There were no differences in the indication for cable or wire group. The operation was performed by two surgeons. The patient was placed in supine position on the fracture table, and lateral percutaneous incision and submuscular tunneling were made. And finally, long CM nail was inserted. For radiographic outcome, tip apex distance, interfragmentary gap, alignment, union, time to union were analyzed. For clinical outcome measure, OP time, blood loss, pain, complication, reoperation were investigated. In the result, there were no statistical difference in operative data, such as OP time or blood loss. In the radiograph outcome of the two groups, the cable group had a significantly smaller interfragmentary gap and lower rate of non-union and shorter time to union. There was no clinical outcome difference between two groups. 62-year-old male patient after falling from a height. Step by step, first incision, submuscular technique, circulate wire passer was placed around fracture site and cable was inserted into the passer. Sufficient force was applied to the cable by gradual tightening like this. Immediate post-operative and one-year follow-up radiograph shows good alignment. Bone union was achieved without complication. This is my recent surgical procedure using circulatory path and cable. First step is traction to restore length and axis. Second step is the putting of passer and cable. And third step is tightening and relieving of tensioner. And IM-nail fixation, final retightening performed. You can see the reduced gap after finally tightening and final check. This is post-operative and one-year follow-up radiograph. Good alignment was obtained without complication. This is the additional notes to my recent surgical procedure using circular passer and cable in abduction position of the hip joint. If the varus alignment and gap of the fracture remain despite proper technique, hip abduction would be helpful to reduce. Most surgeons usually operate in adduction position of the hip joint like this. You can see the varus and residual gap after fixation, like this. At the point, abduction position of the hip joint could be helpful to reduce the remaining residual gap. Abduction should be performed before fixation of the distal interlocking screw. After abduction, varus was corrected slightly and residual gap was minimized. You can compare the two images from CM around the fracture site. You can see the change after positional change. In summary, minimal invasive reduction using a cable is more effective than a wire in improving the quality of reduction and promoting bone union in subtrochanteric fracture. This was published in Journal of Orthopedic Trauma last year. My second suggestion during IM-nail in subtrochanteric fracture, hip abduction position could be helpful to correct residual varus and minimize the residual gap. This will be published in CIOS this year. Thank you for your attention.
So thank you so much, Professor Kyo Taiwan, for a very good technique using cable in subtrochanteric fractures.